to evaluate these patients. So this is a perfect opportunity for interprofessional practice. Principles of treatment are the first unprovoked treatment, seizure. You have to decide whether we're going to treat or not. Is that seizure likely to lead to epilepsy, and this person needs to have medication on board? Once you put somebody on medication, it's not easy to make the decision to take them off. And so if you've made the decision to put them on, they're going to be on for several years. And we're learning more that by taking people off of seizures meds, that we may have more complications. So it's a debate on whether to start or not start. And a lot goes into based on what the potential etiology is. So that's why that baseline information is really important. We select the drugs based on multiple factors, and we'll go through those on slide: conditions, presenting symptoms. So what happens in a follow-up visit? You've made the decision, they've got epilepsy, they're on drugs, and what can the pharmacist and rest of the team do in these follow-up visits? First, you're going to assess efficacy of the medication based on the reduction of seizure frequency, giving the patient diary and evaluating the number of seizures before treatment and after treatment. You're going to go through the various adverse effects from the medication. You should ask about suicide risk because it's one of the black box warnings. We don't see it as a real problem, but because it's a black box warning, we make very good notes in the chart that that's been addressed. And sleep is important because a lot of people don't describe sleep problems. They've just lived with them all their life and they don't talk about them. It's important to ask because seizures may occur while sleeping and they may not be describing them to you. So it's important to ask specifically if there's anything happening in sleep. Talk about it, compliance, and discuss family planning and birth control. These drugs are teratogenic and they need excess monitoring during the time of pregnancy, and therefore it's real important to educate patients that this is something that needs to be planned, and you want to be able to get onto the lowest, most effective dose, and the one that has the least teratogenic potential. And you need to decide whether you're going to get any lab work. Are you going to get any chemistries or drug levels? So when do you decide to get drug levels? We tend to get them at the clinic much more than the general population because we're dealing with refractory people. The newer agents were marketed to not need drug monitoring. However, we generally do because we like to know where we're at. We get unbound concentrations when we have drugs that are highly protein bound and we suspect potential problems occurring that may be related to the free concentration. We evaluate for compliance to make sure we're not increasing doses in patients that aren't reliable with their medication, reinforce that. And sometimes that takes a really detailed history to figure things out. We had a patient a couple of weeks ago that said the Depakote tablets are too big, they're not going to take them. And then we tried to give them another alternative drug. There was an excuse for that. So we sat down and we worked with getting smaller dosage form, and they just ended up taking 3 tablets of that at a time. But there was still resistance, and we checked at the end of the day, and he hadn't picked up his prescription from the pharmacy. And this was a case of a 25-year-old person that was still with mom and didn't want to face epilepsy, and the mom was a nurse and obviously felt like she could control the situation better. So this required a lot more dynamics with the patient, saying you need responsibility for your meds. We'll work with you to adjust your medications to get you something to solve the problem. But the real problem was that he really couldn't swallow pills. He didn't really want to take them. So you really have to get down to the nitty-gritty why your compliance is a problem. If we're having trouble defining whether somebody is maximized on a drug, we might define a therapeutic window for that person. Figure out what level there are that they don't have seizures and the level that they have when they might have side effects. We figure out that window. This is really particularly important when we evaluate patients for surgery, because they have to fail a certain number of drugs before they're considered. And we don't really want people that are non-compliant with their medication or haven't had adequate trials being sent for these procedures. Sometimes it helps us define toxicity to the drug, and we may need it if we want special dosing adjustment. Usually, as you learned from last time, the kinetics of these drugs are pretty simple for most of the part, except for a handful of them. So we don't really usually need drug levels because it's a linear drug, but in some cases, it might be helpful. And in pregnancy, we need increased monitoring. So then after we've evaluated that, we decide whether we want to adjust the dose of the medicine. Do we increase, decrease it? Do we decide to add another drug? Do we decide to add another drug and taper the first one? And how we choose the second drug is based on the pharmacology. And there's a chart in your handout that goes through that. We try to add drugs with different mechanisms, and that way it may approach it from a different angle. First approach is to try drugs as monotherapy. So that means the pharmacist is going to be involved with dose titration and dose tapering off, because you can't be on no drug. So what usually happens is you have a person on a drug, and then you add the second drug and taper the old one off. Now, there's no exact recipe for that, because it depends whether you're taking the drug off because of side effects or lack of efficacy. So if you are tapering the drug because of side effects, you're going to remove the first drug much faster than you would if the reason is because of poor efficacy. So all of those factors come into play in how to do the dosing adjustment. And you'll be asked to do that in your sample cases next time. So then we decide, is a person a candidate to come off of drug completely? Have they been cured of their seizures? And how do we decide how to take them off? And this is a controversial point, because we found that there were people that were well controlled on our first class agents, the ones that have lots of side effects. They were well controlled, and we said, oh, these drugs have lots of bad side effects. We're going to take them off and put them on ones that have less side effects. And there were people, probably about 20%, that were well controlled and switched to a different agent, and then they had a return of seizures. So we put them back on the first agent, and they couldn't be controlled anymore. So we can't really understand why that happens, other than that there are some kind of neurological changes that happen when you withdraw and add drugs. So this is a very delicate situation that you have to be really taking in the whole scope of the picture, because we're just now understanding that the pharmacology is deeper than we understand. So if you come to the conclusion that you're going to take somebody off of drug, there's a chance that they're going to have withdrawal seizures. And even if they have like a withdrawal seizure, doesn't mean that they can't come late. You have to maybe just slow the taper down. So if we decide to take somebody off a drug, we decide a time period that is least stressful for the patient, and allow for 2 to 6 months to do the taper. And we decrease about like 25% every 2 to 4 weeks. And even slower if we think that the person may have problems. We can restart the drug if withdrawal seizures happen, and then just do the taper more slowly. There's no hurry to take these off if we're doing it because they're not having seizures anymore, and you're just gradually lowering the medication. So there's not really a big hurry. The slower, the better chance you'll have of keeping them off. What may happen, because these drugs do have mood-enhancing effects, you may see worsening anxiety or depression. You may see that they're nervous about having seizures again, just psychologically. So you're going to monitor for that and provide appropriately. And then there are going to be a percentage of these people that will not respond to coming off of drug and need to be put back on. So periodically evaluate whether or not they're having seizures. So you can't just discharge them from your clinic. You need to have them act periodically and evaluate. So how do you educate your patient? You tell them that you want them to report any new symptoms, because when you add medication, their seizure description may change. They may get side effects. So it's important for patients to say, anything unusual, please tell us. And they need to be educated about the importance of compliance. And missing their meds is the #1 reason why someone may show up in the emergency room with status epilepticus. Missing medication, either because the patient gets confused or the doctor gets confused or the pharmacist makes a mistake, is the #1 reason that people end up in the ER. So it's important to teach these people how to take their medications responsibly. And patient self-assessment. They have to be in charge of themselves so they recognize, hey, is my drug working? Am I having any particular side effects? Send them to support groups for continued learning. This is where they learn about side effects that are newly released about a drug, or research trials that they might want to participate in, or how someone with the same disease as you responds to certain situations. We had a person working here at Rutgers many years ago who had very refractory seizures. She was seeing the physician there in multiple research trials at Robert Wood, and she would have lots of bad days at work and just not show up. She was very upset when she saw that I was in the clinic, because she knows I work here, and she didn't want anyone to know that she had seizures because she was embarrassed about it. Instead of telling her employer that because she didn't show up because she had a seizure or because she just got on a new research trial and had some very bad side effects, I think that would have gone over with the employer much better than just not showing up for work and not having explanations for poor work performance. So I think there is still stigma about the disease, and people need to be educated that it's a very small part of their lives and won't have dramatic effects for the majority of people, and that we have more and more treatment options for people to improve their quality of life. So informing people about your condition is important, for one, just so that they can understand about you, and also they can observe any changes in you, because these drugs have a lot of cognitive and behavioral side effects to them. And if you have friends and people that are with you, they can observe your seizures when you're having them, or any changes in your mood and behavior. Family members need to be instructed on how to handle a person in status epilepticus, and you need to establish what are realistic goals for the patient, what are their responsibilities, and what are real expectations about how successful their drugs are going to be. Generic substitution is a very hot topic in this field, and for many, many years, the Epilepsy Society fought to try to get no generic substitution for their products. They felt strongly that the brand was very superior to the generic company. And there's all kinds of isolated reports where a patient says, well, I was on topiramate, and then they put me on the generic, and my seizure frequency increased. They come in with diaries to prove it. They had side effects on the topiramate. They had some diarrhea, and then, hey, they're on the generic, and they don't. So they obviously have lower blood levels of it with it. And you can adjust and titrate up and down, but a lot of people have a lot of anecdotal stories that they're not the same. There are subsequent, much larger trials looking at this, and the now is that they're equivalent, and that you should just try the generic, unless you have really, really good documentation from a patient that it's not working. They should be aware that all of these drugs go through metabolic profiles that increase their risk of drug interactions. So anytime they start or stop a medication, they need to discuss it with the pharmacist or the doctor and be aware of what these side effects were. Look them up. You as a pharmacist may not be aware. So when you are filling the prescription, look up each new drug with the epilepsy medication to see if there's an interaction. And discuss drugs that have moderate or high risk of lowering the seizure threshold, because patients may be willing to use drugs that have more toxicity risk in order to have seizure-free periods. If a patient is still having seizures despite maximized epilepsy drug evaluation, there should be referred to epilepsy centers where physicians specialize in epilepsy and can evaluate investigational drugs or potential surgery. And we have a very, very good neurosurgeon here in New Brunswick at Robert Wood that sees very, people from all over the country. He can do laser surgeries, which are less invasive. So in your practice, you should be aware of that this would help certain patients. Patients need to be aware to take knowledge of what are the very triggers for seizures and try to look at their overall health to try to minimize them. And things that are going to aggravate that are lack of sleep, stress, poor eating habits, just general poor health is going to increase your risk of seizures. So we all have to take good health care seriously, but seizure patients have to realize that when they don't, it's at the cost of potential having a seizure. And you want to personalize your instructions for patients based on their literacy level and cognitive level. A number of Parkinson's patients, a number of epilepsy patients that have been born with seizures are part of a cognitive syndrome, and so they have a lot of long-term health complications and may have literacy issues. So it's important that you work at their level. So these are some non-pharmacological treatments: avoiding precipitating factors that we talked about, surgery, vagus nerve stimulation, a ketogenic diet, which is a high-fat diet that's supposed to change brain chemistry, and avoid drugs that are aggravating seizures. And these are drugs that are in your table that are noted to have the highest risk of worsening seizures. And it's going to be aggravated, aggravated by decreased renal function. Sorry, sinus problems. So take a look at the chart that's in your handout. And it has a table of the pharmacology. And what you'll see is that there are a variety of mechanisms that these drugs can have. They work through a variety of different channels: GABA activity, glutamate activity, various other. And when you look at that, I'm not going to ask you specifically if it's a sodium or calcium channel blocker. The concept is, if you start with one agent, such as carbamazepine, and it's a sodium channel blocker, and you're not having adequate control, you might try to consider an agent that has a different mechanism of action and add that one and remove the carbamazepine and evaluate the one with the new mechanism. And as you move down the chart, starting with topiramate down, you're going to see drugs that have multiple mechanisms. And generally, these drugs have more side effects, and so they're not usually used as first choice in many occasions, because even though they have a broader spectrum of activity and may be better in refractory patients, they come at an increased side effects. So generally, we reserve those for patients that aren't responding to the more simple agents. So how do we pick the agent besides looking at the pharmacology? We look at the patient's EEG. We look at how long it takes for the drug to reach a therapeutic concentration. For example, lamotrigine and topiramate take weeks to months to reach their full effect. So if you have a new onset patient that's having lots of seizures, you may not want to wait 6 weeks for lamotrigine to take effect. We look at the side effect profile. We look at the drug interaction risk with their other drugs. We look at their hepatic and renal function. We look at the risk of birth defects and try to avoid certain ones in women that are going to be having children. We look at their comorbid conditions. And if you look at a number of them, I get complaints sometimes that I ask you to memorize this, but these are things you've already learned. That if you look at the chronic conditions, chronic migraine, chronic pain, mood disorders, essential tremor, neuropathy, there's a slide further down that will discuss it further. We have drugs that are treatments of choice for those, and they are often one of the epilepsy drugs. So it would make sense to pick one that would cover both. The frequency of dosing and how it affects compliance. For example, carbamazepine, it needs to be dosed like 4 times a day because of its short half-life. So maybe that wouldn't be a very good choice for someone that has compliance issues. We look at cost and availability to get the drug. So we oftentimes have trouble prescribing some of the newer drugs because they're more expensive, and we have to document that they failed some of the other drugs before we try this one. Now, the issue with the guidelines that I'm posting is that many of them are old, and the first ones that were posted in like 2005, and then they had some updates a few years later. But the one that we have now is actually 2017. I have 2013 on the slides, but on your handout it's correct. They were updated recently, and there's just an extra group. It's the same list of drugs. And the drugs of choice for people with partial seizures, called focal, same group. These are our drugs of choice: lamotrigine, oxcarbazepine, carbamazepine, and levotriacetine. And again, you have to realize that lamotrigine may not be first choice because you may not be willing to wait 6 weeks. So you're likely to pick one of these other agents. And oxcarbazepine, what's the advantage of oxcarbazepine over carbamazepine when you remembered from kinetics? I know you're sleep deprived and waiting for your test, but anyone remember? So it's longer acting, and it doesn't break down into the epoxide metabolites, so it might have less drug interactions. So it can be dosed twice a day, so that's an easier form of giving something similar to carbamazepine. And levotriacetine is currently probably the most commonly prescribed drug because it has the least side effects, the least drug interactions, and so it's probably the one you'll see in 90% of cases. So generalized tonic-clonic seizures are lamotrigine, levotriacetine, and valproic acid. And so again, because lamotrigine takes a while to work, valproic acid has more side effects than levotriacetine. Keppra, levotriacetine. So I think that makes it pretty easy in terms of selection, but not everybody can tolerate that drug for various reasons because of its side effects. And so you might have to go through the list and compare the other ones that you have. The other thing that's unusual about seizures is that some of our seizure drugs may actually aggravate seizures. And the ones that I have listed here will aggravate the generalized tonic-clonic seizures. They will worsen those for patients that have that. So that's an interesting twist. So these are the treatment of comorbid conditions, and they're written out for full in your handout, so that should be pretty easy. So for mood disorders, you've learned in your mood disorder class that valproic acid, lamotrigine, carbamazepine, oxcarbazepine, gabapentin, and topiramate are some of the drugs used in these conditions. And so those would be helpful in people that have comorbid for that. And we have bipolar, and we have migraine headaches, neuropathic pain, trigeminal neuralgia, tremor, and patients with osteoporosis. Osteoporosis is very important in epilepsy. It should be part of your education and monitoring because epilepsy patients start to develop bone loss probably at least about 10 years earlier than the general population. And it may be due to the drugs, and a number of these drugs cause decreases in calcium and vitamin D absorption in the bone, and they've been associated with bone loss. But we're also learning that actually seizures occurring in certain parts of the brain may also disrupt the endocrine system and aggravate patients with osteoporosis. So part of the education for patients is that they be part of bone building exercise programs, that they have good diets with good calcium and vitamin D intake. Asking to measure vitamin D levels is sometimes difficult because it is a cost. It's not a cheap test, and a lot of people don't know which level to aim for. So I would aim for close to 30, between 20 and 30, just to keep them at that level, and that they're doing good exercise, and that they're eating good amounts of calcium, to try to minimize the disease effect on osteoporosis. And lamotrigine and levetiracetam have been shown to have a minimal effect on bone, whereas a number of these other ones have caused bone loss. So just as we have drugs that are good for people that have various comorbid conditions, we have a list of drugs that, based on their profile, may aggravate these conditions. So again, I'd like you to memorize this as well, because this is part of what you've already learned in other classes, that phenytoin, phenobarbital, primidone, levetiracetam, ethosuximide, priapanil may aggravate depression. Lamotrigine may worsen headaches. Ethosuximide, levetiracetam, and tigabapine may worsen anxiety. Phenytoin, carbamazepine, and phenobarb are potent enzyme inducers and have been shown to cause a lot of bone loss. So those need to be avoided. Pregnancy, the list of drugs there have been known to show some severe teratogenic effects, so those are not going to be your drugs of choice. So we have EKG screening that we need to do with lacosamide and ezogabine. And so you want to avoid those in people with myocardial disease. And ezogabine causes urinary retention. So what I had in preparation for this lecture, I have an academic student, Phil, from the last year. He helped me go through your NAMPLEX book that's in the library, and there are 62 questions associated with epilepsy, and we made sure that we've covered it in this lecture, so that should be helpful for you. And they are still asking about drug levels, so I will ask you about these. That was on the test. These are drugs that are highly protein bound. And highly protein bound drugs, when they interact with other highly protein bound drugs, they're going to have an increase in the free concentration. And that free concentration is going to increase toxicity. In most cases, it's not a big concern because it just gets eliminated. And you then have an understanding if a patient tells you that they have peak dose dizziness or peak dose confusion. You look at the drugs and you see that it's highly protein bound, you can explain that, and maybe do some separation of the drugs that are interacting with each other. If you have drugs that are enzyme inhibitors like valproic acid on board, it's going to slow the interaction between valproic acid and phenytoin. It's going to slow the ability to get rid of that free concentration because of the enzyme inhibiting effect of valproic acid. And therefore, you need, by understanding the kinetics, you can understand the side effects of these medications. So the half-life is important because we use half-life to calculate how long is it going to take to get to steady state. Do you remember that? How many half-lives? Yeah, about 4 gets you at least 90%. So that tells you when you can draw blood concentration. And it tells you if you're stopping a drug because of toxicity, how long it's going to take for those symptoms to go away. So that's valuable. And what's unique about the epilepsy drugs is phenobarb has a really, really long half-life. It has a half-life of like, it takes 4 days to have half-life. So it takes over a month for you to get to steady state. Phenytoin is non-linear here, so it's unpredictable. It's going to be based on dose and enzyme saturation. And carbamazepine does autoinduction. It induces its own metabolism. So the half-life when you're initiating is different than it is a month later. It's very important to look at the metabolism of these drugs. I'm not going to ask you to list all of which cytochrome P450 enzyme is inhibited, although your NAMPLEX exam does ask you some specifics. It does say which one is a 3A4, which one's a 1A2. They did have a few questions in there. I won't be asking you that because I feel you can look it on either my handouts or look it up in the package insert. But it's really important because a lot of these drugs interact with each other, and you need to look at the patient's profile and check for these things. You also need to know which ones are eliminated renally and need adjustment, and these are the ones that are listed: gabapentin, pregabalin, topiramate, vigabatrin, levotriazetam. And therefore, you need, whenever anyone is on these drugs, you should check the renal function and see if you need to lower these. What are some other random applications found? Is that valproic acid and carbamazepine have sprinkled capsules. And these may be opened up and put on food, or if you take them whole, that these capsules will appear in the stool. And that doesn't mean that they didn't absorb the drug. It's just how it passes through the body. And valproic acid sprinkles can be placed on the food, but you shouldn't chew them when you do that. And what we learned recently is that valproic acid should not be taken with carbonated beverages. And that is because it causes a breakdown of the product in the mouth, and therefore causes mouth, stomach irritation. It doesn't happen with Depakote because it's encoded, but it's probably not a good idea to take any medicine with a carbonated beverage. We talked about sleep, the importance of sleep, because these drugs may aggravate sleep, and they may be having seizures in sleep, so we need to understand the sleep cycle. And pregnancy, and then when they're pregnant, we need to supplement with folic acid to help try to minimize birth defects with some of the drugs that we have, particularly the enzyme-inducing drugs. So in terms of adverse effects, it's a challenge to review this. So what I would do is memorize the general side effects for all of the drugs, and I'm going to be pointing out what is unique about some of the others. And we've underlined ones that have appeared in the NAMPLEX review, or Dr. Sue and Feller are important because she's going to be following with similar lecture for kids, and we have similar drugs. So you want to look to see if they're concentration related. That means, is there anything in the neurologic system that could be affected? Stomach irritation, Hypersensitivity due to the HLA alleles, and there are various idiosyncratic reactions. So GI upset includes nausea, upset stomach, and diarrhea. Taking the products with food should help some of the stomach upset. Blood dyscrasias can occur with a number of them, but particularly with carbamazepine, phenytoin, valproic acid, phenobarb, and zonisamide. Rash occurs in about 3%, primarily with highest risk agents. If you take any of those high-risk agents and you have a rash, don't put them on any of the other ones that have a high rash risk, because then the rash risk becomes like over 8%. So rash is a real concern with these agents, and patients should be reported if they notice any symptoms. And they usually occur within the first 2 months of therapy, if they're going to have it. CNS effects are vision changes, sedation, slow thinking, problems with walking, dizziness, and headache. Metabolic changes. We see some of the drugs that cause increased enzyme induction are going to affect your thyroid test, your cholesterol tests, your folate levels, your vitamin D, your glucose metabolism. And that's why the people in Philadelphia, UPenn, really tried to get people off of those drugs, because they wanted to improve the cholesterol profiles and the vitamin D profiles, but not everybody was able to come off. Again, because the suicide is an FDA labeling, we do ask about it at every visit, although it's not really a common side effect. It's just, again, covering yourself that you've asked for this. Are there any questions? I know you're brain dead, and I'm trying to get through this so that we can have most of the time for cases next time. I will let you out early, but do you have any questions before I start into the really boring part? You're doing all right? You need to stand? No? Okay. You're filled up with caffeine? Okay. Well, you're supposed to do matcha. You heard that. That's the Zenergy. You have matcha, they agree that's what they're selling it everywhere. So the matcha has caffeine, but it's less than coffee, and then it has theanine in, so that you get the buzz, but not the cardiac effects. Promoting of matcha. So, phenytoin. The thing that you'll see there, and it's on a number of exams, is gingival hyperplasia, which is gum changes in thickening of the gums, and it's important that you work with the dentist to maintain good oral hygiene, and they may require various surgical techniques to debride the extra tissue. It's going to cause a coarsening of facial features. So again, in young girls, we don't really want them to have facial hair or more masculinization of their features as they grow. And long-term cerebellar syndrome, so people that have been on Dilatin for like 20 years, we end up seeing dementia, memory problems in what we call cerebellar syndrome. Hair growth and acne, and then it has the HLA type. So that again tells you that you're not going to pick this drug first choice because of these side effects. Why do you think we still talk about phenytoin? We talked about a little bit about it in kinetics. Why do you think it's just not erased from the list? So when a person comes in with status epilepticus, that's going to be their first time that they're put on a drug. And we have limited number of drugs that we can offer during status. And phenytoin is the one that's on the protocol. So that's why a lot of people end up on that. We try to switch them off, and Keppra is being more promoted, but the official algorithm has not changed. So when you're in an ER, you really want to follow the established protocol. So that's why you end up a lot of people on this. Carbamazepine had those blood dyscrasias, but it also is related to a tricyclic. It can have cardiac conduction problems. It lowers white blood cells. Most of the time that's transient, but there may be a group of people that has it persistent. And the blurred vision and eye changes is often due to the metabolite. So you want to look at the timing of when these side effects happen and look for any other drug interactions, because we're going to learn that valproic acid increases the epoxide, and that may increase that side effect. And it also is an HLA gene. Oxcarbazepine, the difference between the two, again, this one was longer acting, it had less side effects, but it has more hyponatremia, particularly in the elderly, and has ataxia and confusion. Valproic acid was almost not marketed because of severe hepatic failure. The company was smart. They went back and they looked at the profile and found out that it was more severe in children less than 10 and if they were on polytherapy. So when they defined that population, they allowed it to stay on the market. It is a great drug efficacy-wise. If you looked at the mechanism of action, it has multiple mechanisms. But it is horrendous in terms of side effects, and it's probably one of the drugs that has the longest list of metabolites available. So there's stuff that we don't understand about some of those potential active metabolites. So a lot of people gain weight on the drug, and they don't like that. They become non-compliant. It increases the risk of bleeding. So before any surgical procedure, you want to check bleeding time and platelets, and that would reserve or delay a surgery until that's corrected. Tremor is a dose-related response. It can improve with time. And you want to screen people that are at high risk for polyovarian syndrome and bleeding, amenorrhea, abnormal menstrual cycles, because valproic acid will aggravate that. Lamotrigine is known for the rash, and that can be minimized. Do you remember from kinetics? How do we minimize the rash from lamotrigine? Yes. You titrate slower, and you use lower doses if it's combined with valproic acid. So with levetiracetam, the main thing you have to worry about is behavioral changes and psychosis. We talked about this drug generally falling in as being our first choice agent based on what we talked about with the kinetics and the side effect profile. But behavioral problems, it's a high condition in patients with epilepsy, so we really do need to screen for this. Topiramate, again, now we're on that list with drugs that have a lot of great mechanism of actions. One of the AA guidelines from the past recommended is drug of choice for refractory. And the reason is it works really well, but we don't use it first line because of this long list of side effects. You need to take it with lots of water, patient education that there's a risk of renal stones, and you want to avoid it in patients that have a high risk for that. It causes weight loss, and it has cognitive issues related to memory, word finding problems. And it can cause inadequate sweating in kids. So niacinamide is very similar in terms of efficacy related to topiramate, and it also has some similar side effect profiles to topiramate. The neurologist that I work with will, even though it's not in our algorithms, will use this drug frequently when he has topiramate in mind as the drug that he has, because it works similar, but you have to remember the side effect profile. And this drug also has drug interactions with sulfa drugs. Now, drug interactions, I'm going to do it briefly today, over it again, because this is very, very complicated. To know what are the enzyme inducers, and those are listed. Mild inducers mean that they may induce some profiles, there's a lot, in terms of looking at drug interactions, there are a lot of metabolites, and some metabolites may be induced and some metabolites may be inhibited, and a drug could be an inducer and an inhibitor, and it can be induced and it can be inhibited. So that's what makes this really, really complicated. So it's difficult to ask you to memorize all of the specifics, but in general, you'll be asked on boards to know the potent enzyme inducers. Carbamazepine, phenobarbital, phenytoin, and primidone. Those are potent inducers that are going to decrease almost anything. And if you look at the supplemental guide, I give you a supplemental guide that you're going to use with your cases. There's a table there that actually shows you somewhat of the percentages, and you can see which ones are more potent than other agents. And not for you to memorize it, but just see, if you're a table pictorial person like I am, you can see the major impact that phenytoin, carbamazepine, phenobar are potent enzyme inducers, and you can also see that drugs can do both, and that is the main take-home point. Your enzyme inhibitors are listed there, and the main one that I want you to know is valproic acid. The other ones can inhibit some enzymes, but not others. But valproic acid is a more broad spectrum. The thing that's interesting about phenytoin and phenobarbital is that they are competitive inhibitors of each other. So it happens at higher concentrations. So even though they're potent inducers, when they're together at high concentrations, they may inhibit each other. So have I made you excited to want to do epilepsy? It's like complicated, right? There's a big value of having pharmacists in this area because we're the best trained to know drug interactions, side effects, and there's a lot of drugs, a lot of potential to interact, and we really should try to find a venue in which we can be more part of the IPE team for this. And these are the ones that are neither inducers nor inhibitors, so these are great to use as add-on therapy, and this also explains why levetiracetam or Keppra is usually or generally seen as your most commonly prescribed drug. So these are the drug interactions with each other. And basically, if you have phenytoin, it decreases the concentration of almost everything. Carbamazepine decreases the concentration of almost everything. Same with phenobarbital. And valproic acid decreases phenytoin total concentrations and carbamazepine total concentrations, but it increases the free concentrations of those. And it has decreases in topiramate, anti-GABA, but it has enzyme inhibiting activities and increases carbamazepine epoxide, phenobarb, felbamate, lamotrigine, ethosuximide, tigabapine, and zonisamide. So phenobarb. So this is what I want to read to you. How do I turn this on? Battery. That's a battery. The battery's dead. Would help if I turned it on. Okay. So what's exciting about these drugs is they metabolize to other drugs that are active. So the carbamazepine metabolizes to the epoxide, which goes out to the diol. And if you have an inducer like carbamazepine, it tends to accelerate the conversion to the epoxide, but it has slower elimination through the diol, and this builds up transiently. So this is important because while this is high, patients may have CNS symptoms, usually visual symptom complaints. And so you know it's not the drug of carbamazepine is not bad. You just know that it's an interaction here. So if you add an inducer to the carbamazepine, it's going to increase this reaction and explain some side effects. Now, if you add valproic acid on board, what it does is block the elimination. It decreases the conversion over here. And therefore, you have an increased epoxide due to blocking the elimination. It decreases the conversion, and it stays at the epoxide longer, and you can have similar side effects. So it's important to look at interactions with birth control. Those will be on the NAMPLEX exam. They did have questions related to that. And anytime you have an enzyme inducer drug, it's going to require the person to have higher estrogen doses. And this becomes a difficult situation, and you need to work collaboratively with the GYN, but they usually use about twice as much of the estrogen when you have that product. But again, birth controls are a difficult thing to manage, and people have fine adjustments with using one of the many that are on the list. There are not very many that have the high dose. So it's important to have also backup birth control mechanisms and not rely on birth control pills, because it takes a while to adjust people to get on the right amount. If you look at birth control pills and lamotrigine, the birth control pills are actually going to decrease the concentrations of lamotrigine and carbamazepine, clobazam levels. And what happens is, if they're on a hormone pack where they have the placebo week, so when you're off the pills, those lamotrigine and clobazam levels will rise during that week, and that person may have side effects from your epilepsy drug due to that removal of the drug interaction. So again, that's part of the education of your patient in manipulating the medicines. Depo-Provera is one of the most common products used, because you can space how, you don't have to take it all, the compliance is good, you give a shot and you come back later for another one, and so it's really highly recommended. I don't like it in epilepsy patients, because what is the black box warning for Depo-Provera is the bone loss. And we already have a population that has an increased risk of bone loss, so we want to be very careful of that. So drug interactions with hepatitis, epilepsy drugs decrease the efficacy of your hepatitis drugs, and we often get calls from saying that we want you to adjust your epilepsy drug because it's greatly increasing the cost of our hepatitis drugs. So we've been asked to come up with alternative regimens for that. And you want to make sure that you look at the laboratory changes that occur related to folic acid and vitamin D. So I'm going to wait to do status epilepticus for the next time. I'll let you go a little early. But I would like any questions about what I presented today. Nothing? Was it easy? Okay. Well, not easy. You have to do a lot to memorize. But please, I had people come to office hours and say they wish they had studied before they did the cases, because they didn't seem to understand the cases when they were presented. And that's the best way to prepare for your exam, because we're here and we're talking about it. So I know you don't have a lot of time, but after your test, relax a little bit and spend a little time doing the homework. And good luck on your test.
How do you feel now? What? You're gonna send it to me? Man, I'm gonna need a pencil again. Okay. Have I been giving this back to you? Yeah. Oh, okay.